Hello, my name is Dr. Ibukun Adedokun. I am an integrative and functional nutritionist. I was invited by the dean of my department, Saybrook University, where I completed my PhD studies to present my dissertation at the dean's seminar. My dissertation was about addressing food insecurity through a closed-loop referral system. A closed-loop referral system is becoming the future of how nutritional stakeholders address food insecurity. Listen to the presentation and you can leave a comment. Thank you.
We have a treat this evening with two speakers, one from the Department of Integrative and Functional Nutrition and one from the Department of Mind-Body Medicine. We will begin with Ibukun Adedokun, who comes to us, a graduate in 2024 from Integrative and Functional Nutrition. And this evening, she comes to us from Germany, where she is currently living. She earned her PhD, as I said, in 2024, also holds a Master's of Science in Organizational Leadership and a Master's in Public Health. She dedicates herself to empowering individuals to embrace nutrition as a source of healing chronic illness. She has extensive experience as a medical laboratory technologist, health associate, public health advocate, working to connect patients experiencing food insecurity to essential resources. I'm looking forward to her presentation. Take it away. And please begin, Dr. Adedokun.
Thank you, Dr. Moss. Once again, my name is Dr. Ibukun Adedokun, and today I'm going to be talking about my dissertation. And before I start, I just wanted to say thank you to Dr. Moss for extending this invite to me to come present today. Thank you again. So the topic is closing the loop, addressing food insecurity through seamless referral strategies. Okay, there we go. So these are my objectives. I'm going to start with an introduction, the purpose of my research, the research question, the rationale behind my research, my findings in the literature review, the findings after I conducted the research, and a discussion section, the implications and limitations to research, and then a recommendation. So before I start talking about food insecurity, I am going to talk briefly about hunger. So hunger is a physical sensation experienced by an individual when they do not eat. But food insecurity is when an individual does not have access to stable and nutritious food, which can end up leading to hunger. So just a bit of statistics, over 34 million individuals, including 9 million children, are experiencing food insecurity in the United States. And then zeroing it down to South Carolina, 1 in 10 people in South Carolina is experiencing hunger, and close to 490,000 people are facing hunger and food insecurity in South Carolina. And as we see, these numbers changes depending on what the economic status is and over time. And then I found out that the population who are most affected by food insecurity are those living below the poverty level, So why is food insecurity important? Why do we care about it? We care about food insecurity because it can lead to health concerns such as obesity, diabetes, and cardiovascular diseases. So thankfully, healthcare providers are beginning to realize the prevalence of food insecurity and are working together to address this issue. One of the ways they're working together to address food insecurity is through a closed-loop referral system. So what is a closed-loop referral system? A closed-loop referral system is a coordinated approach in healthcare and social services where referrals to services are tracked and followed through from the initial request to the confirmation of service delivery. So basically, it gives the healthcare system it permits the healthcare providers to address health issues outside of the clinical setting. Okay. There we go. Okay, so this is what the closed loop referral system process looks like. So it starts with the screening stage, where the patient goes into the doctor's office, and then they have validated questionnaires that ask them about their food insecurity status. And if they are determined that they have food insecurity, then the clinical staff will then refer them to the food assistance program. So it starts with the screening, the referral is going on, and then they're being referred to the food assistance organizations. And when they review their files and they determine that when they review their file and they see that they're food insecure, then they provide the resources to them, and they turn right back and send information back to the doctor's office, letting them know that this is the patient that you referred to us. We've been able to help them. So that's why it's a closed loop referral system. So it basically follows the patient from when they're screened for food insecurity till the point in time where they actually get the food resources. So the purpose of my research of this instrumental case study was to understand how nutritional stakeholders establish closed loop referral systems for patients experiencing food insecurity. So, however, there's a gap between screening patients and for food insecurity and connecting these patients with food resources. So the gap in literature is what led to the research question, which is how do nutritional stakeholders in the southeastern region of the United States establish closed loop referrals for patients who have screened positive for food insecurity? So previously I talked about the starting stage of the closed loop referral system, which is the screening process, the referral, but patients are getting screened, they're identified as food insecure, they're getting the referral, but they're not getting the resources. There's a break in the link right there. And if you're not getting the resources, basically no communication is getting back to the doctor's office, letting them know. So there's like a crack in the provision of services. So the rationale. So basically, I want understanding the mechanism and strategies of nutritional stakeholders in addressing food insecurity can help with the evaluation of the process down the line. And then it also helps to promote continuity of care and reduce the resource allocation gap. And then to basically the rationale also is to examine the collaboration. I wanted to understand the collaboration. Are there challenges? And what is the workflow like for a closed loop referral system? And then understanding the closed loop referral system will help to identify best practices, and then basically how can those practices be further improved? And then basically it helps to promote appropriate interventions for those experiencing food insecurity. So these are my findings for when I did my literature review. So as I mentioned earlier, there's a prevalence of food insecurity. And basically in the United States, prior to COVID outbreak, approximately 10% of households experienced food insecurity, particularly among the low income and minority groups. And then when the COVID-19 hit, that further worsened the situation, and basically due to unemployment and the economic difficulties. And basically, what does that look like in terms of percent-wise? So for example, in the United States, household food insecurity increased from 11% to in 2018 to 38% in March 2020. And of course, there are causes of food insecurity as well. So it is important to note that there's often no singular cause or situation leading to food insecurity. Instead, people may become food insecure for a variety of reasons, such as poverty, unemployment, reduced income, and the list goes on. So basically, food insecurity, as I mentioned earlier on, has an impact on health. And this could be in form of malnutrition, obesity, mental health, and just to zero in on malnutrition. So this is when an individual does not consume enough essential nutrients for healthy growth and maintenance of their body system. And so basically to zero in on obesity too. So the one might think, oh, how does obesity begin to relate with food insecurity? So basically they're eating, yeah, but then they're not eating nutrients dense food. So rather they're eating calorie dense food. That's how they're able to which can result into obesity. So the other findings were that food insecurity, systemic racism, and racial discrimination also causes food insecurity. And then I also found the screening for food insecurity in healthcare systems. So basically, healthcare systems are screening for food insecurity. And one of the tools they use is called the hunger vital sign. So if the patient can answer yes to either one of the questions, there are two questions. If they can answer yes, then they're determined as being food insecure. So the first question is, within the past 12 months, we worried whether our food would run out before we got money to buy more. And the second one is, within the past 12 months, the food we bought just didn't last. We didn't have money to get more. So if they, once again, if they can answer yes to any of those questions, then they're determined food insecure. So basically, what is the importance of routine screening for food insecure patient? How does this help? So routine screening of patients allows healthcare providers to identify individuals experiencing inadequate access to nutritious food, so and which can help to facilitate and promote the intervention and support for people for patient experiencing food insecurity. So basically, the present studies on the effectiveness of food insecurity screening in healthcare. That was another finding. So research indicates that food insecurity screening in healthcare setting helps to identify and assist individuals and families who are at risk. And this helps to lead to timely intervention. So there's no gap in treatment. So basically, the next finding was nutritional stakeholders. So when I talk about nutritional stakeholders, I'm referring to the doctors, the registered dietitian, the nutritionist, the registered nurses, social worker, community health worker, family navigator, and the staff of community-based organizations. Those are the nutritional stakeholders. They all work together to be able to ensure that these patients are taken care of. And then, of course, there are challenges and barriers to establishing closed-loop referral system, and then which will be discussed later down the line. And other types of referral system that I found out are open referral system, service referral system, and telehealth referral system. And the one thing that stands out, the one reason why closed loop referral system stands out from the other type of referral system is because it is the one referral system that follows the patient from the point of screening till the point where they actually get the resource. So they're not just left alone to tread waters by themselves. There's a follow-up constantly going on. So the methodology section. So my role as a researcher was to conduct an instrumental case study, a qualitative study, and present the findings. So to achieve this goal, I collected data through archival records, focus group, and semi-structured interviews. So I'll be discussing and the purpose of the instrumental case study basically was to focus on gaining insight into a specific issue or phenomenon, which is how nutritional stakeholders establish a closed loop referral system. And so that's the basis of the instrumental case study. So for my research method, again, I did a qualitative research, I did an instrumental case study, and the unit of analysis for this instrumental case study was the nutritional stakeholders collaborating to establish a closed loop referral systems for patients that are experiencing food insecurity. And basically, I did it from the month of September. I looked through the month of September 2022 through the month of September 2023, which was my case, the timeline. And basically the theoretical framework that I used was Cutcher's 8-stage process because I was dealing with a change process. So that was what I used to basically help me to understand the process. So for the data analysis, basically my data sources were archival records, focus groups, and semi-structured interview. And then in order to analyze my data, I used the Bronze and Clark's thematic analysis. Basically, I familiarized myself with the data. And then once I was familiarized with the data, I generated the initial code. I searched for teams, reviewed the teams, defined and gave the teams a name, and then I produced the results. So these were the following processes that I followed in order to ensure rigor of the research. And then these are my findings. So basically, I found that integrating healthcare systems are integrating standardized screening tools into routine patient assessment to identify patients with food insecurity. And then when they identify these patients, they develop transparent referral workflow and collaborate closely with community-based organizations to connect them, to connect these patients that are experiencing food insecurity with food resources. And then to complete the closed loop, they implement a digital and secure data sharing platform to track referrals and provide follow-up. And then I also found out that there are barriers to establishing closed-loop referral systems. And then as I discussed with my participants, I realized that they also offered possible solutions to reducing these barriers or addressing these barriers. So basically, this is a slide that shows, I'm just trying to minimize because it's blocking on my end. Okay, there we go. So this is how the site, the medical facility that I did the research on, this is how a typical closed loop referral system operates. So basically, like I said, the screening process, the screening and identification of food insecure patients by the hospital clinical staff. So when they identify them as being food insecure, they refer them to the clinical staff, then initiates a referral. And then this referral either goes to the family navigator or the community health worker. So it goes to in the subsequent slides, I'll be showing the different examples of how a family navigator would operate and then how the community health worker would operate. So basically, when they receive that referral, the family navigator or the community health worker will contact the patient, get their consent to receive food assistance. And then when they receive the patient's consent, they would now forward their information to the community-based organization as well. And then they would also contact the community-based organizations. So once the patient gets the community-based organizations and receive help, the community-based organization will then contact the clinical staff back or the family navigator or community health worker, letting them know that the patient that is referred to them has received help. So this is an example of closed loop referral system, how a family navigator will handle it. So a closed loop referral system for patients with pre or diabetes and experiencing food insecurity. So for this particular situation, the patient had to be pre-diabetic or already have diabetes, and they're also experiencing food insecurity. So basically, once again, the referral is auto routes to the family navigator from the clinical staff. So the family navigator confirms the food insecurity needs of the patient, obtains their consent, and verifies the patient's health status. So once all that is done, once the patient agrees to receiving resources, the family navigator creates a referral for the mobile farmers market. So, and then the mobile farmers market staff will then review their information, contact the patient, and offer them free nutritional class and weekly groceries delivery for the first 6 months. And then once they start helping that patient, they would get back to the family navigator and let them know that, hey, the patient you sent to us, we are now helping that patient and that patient is receiving help. So in the case of the community health worker, it's also the same thing, but the only difference is that as the community health worker the community health worker also addresses other SDOH needs that might be in form of like depression or needing transportation or housing issues and all that. So basically, if the patient has 2 or more SDOH needs, including food insecurity, then they get routed to the community health worker. So the community health worker reconfirms their needs and gets their consent. And then if the patient agrees to receive resources, the community health workers then contacts the community-based organization and then they follow the patient through till the point where they are more in a more stabilized state. So, sorry, go back. So in terms of the discussion, so basically screening and identifying patients with food insecurity, as I mentioned earlier on, that is the starting point where so for them to begin to, for healthcare providers or nutritional stakeholders to begin to address food insecurity, the starting point is that they have to be screening those patients and identifying the patients that need help. So basically, so when they screen, that the screening emphasizes that when they screen, it shows that they're identifying patients with food insecurity and that they are acknowledging that it is prevalent. And so basically it is the first step. And then acknowledging that food insecurity is one of the SDOH concerns that could be, and they're also acknowledging that it could be one of the underlying cause of why a patient needs medical attention. So an example of that, when I was discussing with the participant, so sometimes the patient will come to the hospital, to be specific, the ER, and after they've run the test, they've done everything that they could do, they would realize that the patient is just hungry. So basically, so some of their patients will come to the ER because they're dehydrated, and then basically their issue is that they're hungry. So it's not all the time that they're always sick. So basically the routine screening helps them to identify food insecurity before they get to the worsened stage. And then it also gives the hospital staff a holistic standpoint of view on how to so basically they might be going through one thing, but then if they're experiencing food insecurity too, so that, like I mentioned earlier on, might be because they're unemployed. And then when we look down into the mental health issue, they might be experiencing a sort of shame or worriness of having to deal with food insecurity. So all that plays into that. So if the hospital is able to screen at that point, it helps to address these issues for the patient. So basically initiating food, once the patient have been determined to be experiencing food insecurity, then the clinical staff can initiate food insecurity referrals. And then the particular site that I worked with, they are required by the Center for Medicare and Medicaid to screen patients who are 18 years and above during inpatient admission. So automatically, if a patient comes in and they're 18 years and above, they're going to be inpatient, they automatically get screened for food insecurity. And for their outpatient, it's done once a year or as however needed. And then once that is done, they connect patients with food insecurity to the community-based organizations. And one of the things that needs to happen is that there has to be partnership or networking of some point between the hospital and the community-based organization. They need to be able to communicate with each other, letting each other know. So from the point of view of the hospital, they need to communicate with the community-based organization. Hey, if I'm going to refer a patient to you, what are the requirements? What would you need me to do? And how would you want me to send over that information to you? So things like that, that kind of discussion happens in the networking stage. And then, of course, there are barriers to establishing a closed loop um, referral system. And some of the barriers that I was able to get from my findings is limited capacity in community-based organization. And what do I mean by that? So community-based organizations are run by volunteers, and these volunteers are unpaid volunteers sometimes. And they're not capable of taking on full-time workload because they have their life of their own, and then they need to be able to pay their bills as well. And sometimes their systems are complicated, and then not all the volunteers are computer literate. So that adds an added burden that, creates an added burden. And then the other barrier is restrictions to data sharing. So due to HIPAA laws, the hospital are really careful on the type of information that they share. So they're really careful not to share too much information about their patient. And then low funding for community-based organizations. So community-based organization or nonprofit organization, as we know, are funded mainly by grants. So to begin with, they don't have enough money with them, but then so trying to hire more people will be out of the question. So for a community-based organization, sometimes they might need a grant writer, and a grant writer will put them in a position to get more grants, but they don't even have enough money to begin with. So hiring a grant writer will probably be out of the question. So, and then the other barrier is incomplete bi-directional follow-up mechanism in the hospital's electronic medical records. So what I mean by that is that information has to be passed down in real time. So the hospital system has to have a system whereby they can communicate with the community-based organization in real time. So if and the hospital has to put it in place, and that in such a time whereby if they're inputting their notes, the community-based organization can also see those notes and act upon it and get information back and forth. So the possible solutions that they suggest that they talked about were increased funding. So basically, if the fundings are increased for community-based organization, they can continue to hire more volunteers and even pay them stipends as well. They can hire more paid working individuals. And then also for the they also talked about a hospital EMR with a standardized closed loop referral protocol. So basically, as I mentioned earlier, if the hospital has a standardized protocol whereby they're still following HIPAA, they're not violating HIPAA, and then they're still able to send information to the community-based organization, then that bidirectional factor can be taken into consideration. And then another way to reduce this barrier is a good support system. So the research site that I worked with, they really had a good support system to the point that they were able to hire a family navigator. They had 5 community health workers, and I still keep in touch with them. The last time I spoke to them, they were hiring 8 more community health workers. So basically, they have people's good support system that understand that they need this. So, and they're getting the grants. They're also funded by grants as well. So they're getting the grants that they need. So, which is a good thing. So when you have a good support system in form of your upper management, realizing that this is something that you need and they're giving you the resources, that really helps things. And then the other ways to overcome this barrier is building lasting relationship. As I talked about, for a closed loop referral system to occur, there has to be networking, and then the community-based partnership has to be formed between the community-based organization and the hospital themselves for a closed loop referral to be a success. So implications for the research. What are the implications? So there is a need for continuous development of screening tools and protocols to identify patients with food insecurity, it is important to understand best practices for initiating referrals to reduce gaps in care for patients with food insecurity. As I mentioned again, partnership between nutritional stakeholders and community-based organization is crucial to establishing closed-loop referral systems. And then addressing these barriers to establishing closed-loop referral systems can enable stakeholders to continue to address food insecurity. And then limitations. So because I did a qualitative research, a case study, and I had limited generalizability due to the specificity to the healthcare setting and then a community-based organization. So my group of participants were not a huge sum of size. So I'm limited in generalizability for that reason. And then because I was dealing with self-reported data, this may introduce bias due to varying perspective or motivations. So the recommendations. So basically, leaders and policymakers should secure additional fundings for community-based organization and enforce standardized protocols and secure data sharing. So policies that help community-based organizations and help enforce standardized protocols can ensure that bi-directional communication is going on between the person referring and the person providing the resources. So nutritional stakeholders should develop partnership between local food resources and further research on how to increase the capacity of the community-based organizations can also be done. And then basically longitudinal studies can also be done. This helps to show the long-term effects of the closed-loop referral system. And the other component that I actually didn't do in my research is the cooperation of the patient. So it's not only about the community-based organization or the referral going on, or the clinical side or the medical facility referring the patient also has to cooperate. So basically research on what is the level of cooperation of the patient, is also required in this is also required to be able to determine how effective the closed loop referral system will work. And with that, this brings me to the end of my discussion. These are my references.
Thank you so much, Dr. Adedokun.